We have to have that conversation about the National Health Insurance Scheme, the National Health Insurance Authority. And this morning we've been joined by the CEO, Dr. Victor Asare Bampoe. And he's in studio with us. Doc, good morning. Thank you very much for joining us.
Good morning, Winston. Always a pleasure coming back to Joy.
And the fact that the people say we are twinning, almost.
Absolutely.
The two of you had a conference and decided to wear the same colored fugu, and you left me out.
I was actually planning to wear something like yours.
Why didn't you wear it?
What you see is what you wear. In my case. When you're looking for the batakari, what you see is what you wear.
Yeah.
Actually. You don't. So once I saw this one, it looked good, and so I wore it. How are things at the National Health Insurance Authority?
They're quite good, and I'll explain. Things are going well. We've got incredible support from His Excellency the President and from the Minister of Health and the Minister of Finance. So in terms of funding, I think it's never been better. So I'll explain as we go along, but that's the first step. And then there are other things that we're doing to make our services even better.
Let's talk about funding because, in the past we've had people complaining, some of your providers complaining about non-payments. When you say funding, this is the best time. Tell us about the funding arrangement. What's changed with funding?
Okay, so before His Excellency became president, when he was campaigning, he talked about repealing Act 947. That was the capping act. And as soon as he came in, he did uncap the National Health Insurance Fund, which means that we have an extra 3.5 billion every year. At least last year we had an extra 3.4 billion. So in consequence, what has happened is that all that money has been channeled to us. We are paying now regularly. Every month we pay providers at the end of the month. In fact, when I leave this studio, I'm going to sit with my team to make sure that the February funding is paid. And this has been going on since January. When we came in February last year, we paid, there was some little amount of money that had been hanging from 3-4 years before we came in, just tiny amounts, but still amounts nonetheless. And since then, from February last year to now, every month we pay the funding, which has resulted in increased confidence in the scheme from the providers. And I can tell you that last year we had 18 million people on the scheme. Now we have over 22 million people because there's also the increased confidence. So fully 66% and a little bit more of Ghanaians are covered by the scheme.
And talking about the fact that you're paying these funds, are you also getting your releases regularly?
Absolutely. I was saying before the show that there are three figures, we call them the golden numbers, that are important to us at the National Health Insurance Authority. The first one is how much we estimate to get. You know that over 90% of our funding comes from the 2.5% National Health Insurance Levy. And then we have some money coming from SNIT contributors, 2.5% of that. And there's an estimation of how much we'll get every year. That's the first golden figure. The second is what is appropriated or allocated to us in the budget. That's the second figure. But the most important figure is how much we are actually allocated. And thanks to His Excellency the President, the Minister of Finance, and the great advocacy of our Minister of Health, for the first time in 2025, those figures merged. So 10.07 billion was what we were expected to get. 10.07 was what was put in our budget. And 10.07 is what we got. It's never happened before.
And talking about the 10.07, I'm actually interested in how much we spend because in discussing issues about sustainability also, it will be important to know, for instance, whether the amount that you get, and the amount that you spend. So in 2025, of the 10.07 billion that you got, how much did you spend?
Okay, so I think let me flip the question back a little bit. For us, the important thing is what do we do with how much we get?
Sure.
So the efficiency question. But how much did we spend? We have a little surplus to tide us over. But that is what we are also using to do the retooling. And retooling is important in the discussion that you are having before around emergency care. We're doing some serious retooling. We're using it to build the resilience in the system. We've spent enough to pay all the claims that came up in 2025. We are not owing any provider if the claims have come through and have been vetted. Unlike previous years, stretching back, I used to be on the board of the National Health Insurance scheme years ago, so I know how it has been. But unlike previous years, now we don't owe anybody. We have a little bit. And as the Minister of Finance says, yesterday I was in a meeting with the Minister of Finance and the Minister of Health, and he said we are even going to pay you even more promptly. I don't even know what that will translate into, because he's paying us so promptly, And he keeps saying, you are a fund, you are a health insurance fund, so you must always have funding to do what you have to do. So there's that confidence from them as well, that they are giving us the money that we need to do. So we have a little bit, to tide us over and to do some of the important things that
you talk about, the retooling that you talk about to build resilience. What are the retooling that you're doing to build resilience?
So, that in the manifesto of the NDC, what His Excellency the President promised was to give us end-to-end health coverage under what we call universal health coverage. Now, universal health coverage means that every Ghanaian living everywhere can go to a point where he or she can get health without financial hardship. And there are three legs upon which it stands: geographical coverage, service coverage, and financial protection. We come in on the financial protection bit. But if you go to a hospital and it doesn't have the tools, or it doesn't have what it takes to deliver, then we haven't done much. Now, there are two other things that are going to happen under the manifesto. One is Mahama Cares, and I'll come back to that. That is where my sister Obobia is the administrator, doing a fantastic job, because we realize that fully 42% plus of all-cause mortality, the deaths that are happening in Ghana now, are due to chronic diseases. That's why we've pivoted to make sure that we have an agency that takes care of chronic diseases. Then very soon, His Excellency the President, the Minister of Health, will be launching what we call the Free Primary Healthcare Initiative, which means that whether you have a card or not, once you are a Ghanaian, you can go to certain facilities, the CHIPS compounds, the health centers, the polyclinics, and get a basic minimum health care package, receive care without even having any problems. You should have that. So the retooling is to make sure that the facilities are ready to provide this free primary health care. Some of the retooling, more under the Mahama Cares, but some of the retooling is to make sure that the bigger health facilities are also well equipped. I was surprised. I was talking to Obobia the other day. She's doing fantastic work, by the way. She's did a needs assessment. And there are some facilities. In fact, she went to, I think, 21 facilities. There are only 5 mammogram machines, very few MRI machines, very few CT scan machines. So this is all part of the larger retooling efforts to make sure that these facilities have what it takes to take care of Ghanaians.
So if I get you clearly, the retooling that you're doing, part of the retooling is to assist in the provision of critical equipment to our health facilities.
Yes. But let me make it clear that we are doing part of it. We focused more on the free primary healthcare aspect of it. The Ghana Medical Trust Fund is looking at the other end, where it comes to the chronic diseases and so on. So we're all doing this retooling together. But like I said, and she often likes to say that where the NHIA ends, then Mahama Care begins. So we want to provide a seamless experience for Ghanaians, from the free primary health care to the regular NHIS, the scheme, to the Mahama Cares or the Ghana Medical Trust Fund. Chronic diseases, I won't call them regular, but the normal diseases that we take care of, and then the free primary health care, which we'll take care of. The important thing I must mention about the free primary health care is that it's not only looking at curative, it's looking at prevention, it's looking at promotion, which is something that hitherto we've not focused on. Because for many of the chronic diseases, if we look out for them early, we can catch them early and prevent them from going to that other extreme. So, for example, if you're checking men's PSA, you can catch prostate cancer very early. Or if you are checking people's blood pressure, you can catch the stage 4 or whatever hypertension and the things it will do to your eyes and to your kidneys very early. So we want to make sure that, and that is a way of also using the money that we have more efficiently, because you know that now the donors are pulling out, right? So it's important for us to make sure that we catch some of these diseases early. One of the things that we know is that if you have somebody in your family who has a chronic disease, sometimes it leads to penury in the family. There's a lot of poverty, because imagine that you have to do dialysis 3 times a week. Apart from the fact that above a certain line, I think that has changed now, but for a long time, if you went beyond Kumasi or Sunyani, you wouldn't have somewhere to do dialysis. So imagine somebody with chronic renal failure in Tamale or Boku or somewhere, having to come down south 3 times a week. You sell your TV first, you sell your car and all that. So that is what we are trying to change. Trying to make sure that we detect these early, but even when they are detected, there are places where they can be taken care of.
Let's talk about the primary health care, the fact that you're focusing on the free primary health care. You have advocated that we can get to the stage where healthcare delivery is free in this country. Can we?
I think eventually that is the aim. I talked about universal health coverage, where the most important thing is, and I talked about service provision, service coverage, population coverage, and financial protection. So when Kwame Asare Bampoe gets up and I have a headache or I have some problem, I should be able to have a place where I can get the service. I should be able to do it without dipping my hand in my pocket and getting it at a very highly subsidized or free, but nothing is free in this world. But it means that somebody is paying, but we are channeling the funds to make sure that our people are okay and they are not suffering financial hardship. We can do it if we are efficient with the use of the resources, if we focus on making sure that the people are, we try to turn off the tap so that we don't have people getting sick to the place where it's more expensive, because the more chronic the disease, the more expensive it is to take care of. So that's where the prevention and promotion are also important, and they come in.
Great. So that would take me to a discussion we were having earlier, and since you were listening while coming in, because I was having this conversation with Kujako Tobati. So I'm a SNIT contributor. 2.5% of my basic salary goes to the National Health Insurance Scheme. I also have a private health insurance, I'm on a private health insurance scheme provided by the Multimedia Group. So I pay as insurance is expected to be, to help others also. So if I suffer an emergency where I do not readily have money, why should money be the barrier for treatment when I, as a SNIT contributor, I've been paying thousands of cedis to the National Health Insurance Scheme?
So this is an excellent question and a serious one. I mean, I know that it's been topical. So I'll start by telling you my own personal experience.
Okay.
In 2023, in September, I lost my mom. I was then working in Geneva as a director in the UN, and it had to take me. There are many examples, but I had to call people that I know in Ghana, sitting in Geneva. Can this ambulance go and pick her, using the personal connections? It shouldn't be so.
Yeah.
Even more recently, a few weeks ago, a director in my office who takes care of my office, she lost her mom. Because of something like this. So there are some parts of the health system that we really need to work on, and there's no gain saying the fact. We really need to make sure that we work on those things. However, there is the rhetoric or what is on paper, and then there's the reality. When you come to the National Health Insurance Authority and the scheme, all the things that you need if you suffer from an adverse event that takes you to the emergency ward is covered. They are all covered. When you look at the guidelines for accident and emergency from the ministry, you know that's the policy making body. It says that you don't take money from somebody until you stabilize the person. So it's on paper, that is what it is. However, we know that it's not working for some reason, and that is what we need to fix. 3 things I would say. Number 1, I know that the retooling will help, because sometimes the systemic failures, we sometimes reduce it to, it's a bed. But the bed, as you were saying just before we came on air, it's a whole unit. It's an ecosystem. It has to have the trained people, the tools for the people to do the work, the attitude of the health workers, and so on. So we need to look at it in totality. That's number 1. Number 2, I know that the health minister upon whom this rests is very concerned about this issue. I'm sure you heard yesterday from Parliament this thing about the integrated bed management system and things that they are going to be putting in place and so on. So there is a problem, and I know that from the right quarters they are trying very hard, and we are all supporting the minister to make sure that this is fixed. Because it sometimes I hear this thing about, and it's a legitimate concern. Oh no, some people don't suffer from this. That's why you never know when this will catch you. And maybe I don't want to be dramatic, but I've seen people have heart attacks. It doesn't matter who you are. If it gets you, right. Like sometimes I think, okay, so if something happens to me here, where's the nearest facility that I'll make sure that I have a chance of survival, and it can affect anybody. So it's best we do it for everybody, and I think that they are working on it, and we are all supporting. One last thing I'll say is that let's not discount what Mahama Cares is doing. Remember that I'm sure you've heard that there are some 3 state-of-the-art cardiac catheterization. This is difficult. Catheterization. Labs that are being, so cath labs are being set up. Not only the cath labs, it comes with ICU. But it may have been reactive because of what happened to the doctor. But you see, we can't let perfect be an enemy of the good. You see a gap, you try to fix it, and as we go along, we try to even preempt so that we don't have the gaps catching us out.
You make a point. You talk about, you ask yourself the question that if something were to happen to you, where can you go? And I on Monday when we're having the conversation with Professor Nicholas Osei-Jenning, for instance, we asked him, and he talked about how if anything happened to him in London, or say in the greater UK, he knew that his chances of survival very high. Same cannot be said about Ghana. So in your education and your retooling, have you considered these? Because then there's the fear in this country, and I tell myself all the time, when sometimes in conversations when boys say, all die be die, so let me enjoy, I don't know when anything would happen to me. We say, Ghana is set up not to protect you, but to kill you. As much as we joke with these things, the reality is that many people just don't trust in the system. From your point of view, from where you sit, what is it that can be done to change this perception, but most importantly, solve the problem?
Okay, excellent question. And once again, just to make it very clear that this is under the ambit of the Ministry of Health, I'll share my perspective, but we have an important role to play. And it's important, and it's very interesting for me because people were saying the same thing about NHIA, that, we don't trust it, they don't pay. It's changed. Like I said, every month we're paying. There are still challenges, yes. We are working on it. We have built the confidence. We are increasing tariffs this year. After the approvals we are seeking the approvals. Once they go through, there's confidence coming in. We can only try to do what is right and make sure that the confidence comes up. And I know that, like I said before, there's work being done. If these cath labs come up, and I know that it's at Kolebu or wherever, if there's an adverse event when it comes to my heart or I have a blockage, it's very easy to point. So you actually have to put the things, I talked about the retooling that is happening. Once those things are put in place, the confidence will come back. We can't say it into existence. We have to prove it. And we are already walking the talk with the uncapping of the funding, the fact that we are putting the resources in the right places. And I think eventually we will get there. We need to get there in a hurry. And I think from what I've seen at the ministry with the minister and others working, Ghana Medical Trust Fund and so on, I think we're getting there.
Now, Doc, when we talk about emergency, one of the key institutions is the National Ambulance Service. What's your relationship with them?
We don't have a relationship with them beyond that. We are also an agency under the Ministry of Health, like the National Ambulance.
It's part of our National Health Insurance funding dedicated to ambulance service that is transferred to them regularly.
So it's part of the Ministry of Health funding,
not NHIA
that
funding.
comes through us. We're just a conduit. Yes.
And have we been giving this to them?
Absolutely. Absolutely. That's
Every
why,
year, without fail.
That's what I'm saying, that this last year, I can only talk for 2025, every single penny that was in our budget for them, we've given to them.
Let's talk about the universal health care. So people who don't even have NHIA cards can walk into hospitals and get the minimum care.
The free primary.
The free primary, if approved. How are you going to check fraud with this? Because even with NHIA, people with cards go to hospitals, they need to go through processes. But over the years, we realized that fraud was one of the big things that was affecting NHIA. How are you going to check fraud in
also an excellent question. You remember I was saying that it's not only about the quantum of funding, but what we do with it. Fraud is one of the things that keep us up at night. There are two things that we're working on this year. So I'll describe to you the NHIA that we want to see, where we want to get to, and I've already talked about most of it, where we are working seamlessly with the free primary healthcare, Mahama Cares, with us in the middle, providing end-to-end coverage. Fraud is that big animal in the room that I think we need to deal with. The way we are dealing with it is we're using technology to a very large extent, and also education of our members so that they know what is expected of them, what shouldn't be done to them. So like with the fraud and with the technology, we think that maybe 15 to 20% of our funding, and this is just a conservative estimate, is not going to what it should be. Actually, it should be going to. So we've employed AI, for example, to look at the patterns of our claims. Let me dial back a little bit up to now, and this has been going on. We didn't start this. Previous regimes have also contributed, so everybody has added a little bit. Now, sometimes some of these facilities allegedly would take claims from one region and present them again in another region. And what AI would do would be to detect these patterns. We ran a test, we've put the AI system in place, and we could see that it was already stopping some of these claims. So we think that once we employ the AI wholesale, we'll see a dramatic reduction in some of these duplications. We also have this one-time code. So for example, if Kojo goes to a facility and there's a certain code that is generated that comes back to your phone, and then you can verify that you've been at the facility. If you've not been there, if somebody else is using your card, you will not get that code. We're also using blockchain technology. We'll be starting very soon, so that any transaction from end to end is protected from anybody trying to fiddle with it and change the figures and so on. Most importantly is the attitude of the people, and making sure that there are platforms that people who suffer these adverse events in the facilities can report to. So if you go to a health facility and you dip your hand in your pocket when you are not supposed to, You must have a place where you can report, and then we can take action. Now, the most important deterrent is what we do when we discover. I remember there was a hospital whose name I will not mention, and we found that they had done some creative accounting. And so I was telling somebody, I said, some very big person, I said, this is what we've done to such and such a hospital, they are going to pay back. And the person said, are they being prosecuted? We need to apply the sanction, because this is taxpayers' money. We need to make sure that we guard against it. And like yesterday in the meeting that we had with the two honorable ministers of finance and health, the minister of finance was very clear. He said, look, we'll continue to give you the money, but you see that fiscal space is shrinking. So you need to make sure that you make more efficient use of the money. And the only way we can make sure that there is confidence in us to continue to get more funding is to demonstrate that what we are using the money for is exactly what is written on the label, and that we are trying to reduce fraud by as much as possible. And like I said, this year, 2 things: sustainability of funding and also checking of the fraud.
Has it come to your attention that some providers, healthcare providers, prioritize every other thing but National Health Insurance Scheme members? So I travel to the road, and my work is on the farm. Almost every other week we go to the hospital. And I noticed that if we are paying cash or when you're on private insurance, some priority is given to you than those who have health insurance. Has that come to your attention?
So 2 things I'll say to that. What are you doing about it? 2 things I'll say to that. Number one, you see, sometimes when I hear these things and I look at the number of health facilities that are still trying to register, get accredited, then I wonder, because everybody, can I get the credentials? Can I, so I wonder, because if they didn't have the confidence, that's number one. Then also the number of people on the scheme, so I hear a lot of people who some people who say, oh no, this scheme, but they are using them. I've visited 12 regions. I'm yet to do the 4 remaining, and there's a high level of confidence, especially now, because we are also reimbursing more quickly. And I'm not the one saying it. We have 22 million Ghanaians, 66% of Ghanaians on the scheme. If it wasn't working, they wouldn't be coming onto the scheme. Finally, we are actually, some of the challenges we've had is because we are purportedly not paying realistic tariffs. We're seeking approvals, and we'll be shortly, I cannot tell when because it doesn't fall within my remit, but we have the tariff structure which has been revised, and we'll be paying, tariffs that would be much more the real market prices, and that will make us even more attractive. I can tell you, for instance, that I saw some of the new tariffs, and for some I don't want to mention some of the conditions or some of the things, they're even more attractive than what the private insurance firms are offering. So, in fact, we think that when we implement the new tariffs, we'll have a rush on our system. And that's why checking fraud is most important. Because imagine the amount of money if we are paying 200 million CDs every month. If we are saving even 10% of that, with fraud detection measures, that goes a long way, So
by the end of 2026, where should we see the NHIA? You've moved from about 44% to now 66%?
66%. No, we're 56% last year.
Okay.
So
44 around 2024, 2025.
No, 2024 it was 56%.
Okay, then you're now around 66%.
Last year, 66%.
Are you hitting 100%?
We want to get to 70. You see, we can push for 100%, but we also need to make sure that some of the problems we are talking about this image, because what's the use of a card if you cannot get the full benefit? So sometimes people say, oh, NHIA, you are not saying what you're doing. It's important to let people know, but it's more important for the work to speak for itself. When people are confident in the system, they get what they need to get. This thing about emergency is very important. And, once those problems are solved and we push to 80, 90%, then we're in a good place. But the thing is also that if you push to 80 or 90%, then you are increasing the amount of potential fraud. So we need to, it's like you are burning the candle at both ends. Whilst you are pushing the numbers up, you are making sure that you are also increasing the efficiency of the system.
You talked about reviewing tariffs. I mean, if approved, so what are we looking at? From what to what rate?
I wouldn't want to say now, but it's a significant jump.
How soon would they be approved?
Well, it's not, like I said, it doesn't lie, as some African right, it doesn't lie in my mouth to say. But we are, there's a process. So we have a whole stakeholder process with consultants, and so they look at the numbers, then we go to our board, then we go to the minister, and then he looks at it, and then he says, but we're far advanced.
Currently, just by way of refreshing, currently what's the tariff? Currently, what's the amount
for
subscription?
Oh, so it depends on where and it depends on which category. You are a SNIT. Yeah, so you don't pay any premium, you don't pay any processing fee. So sometimes it's from about 10 CDs to 48 CDs when you come to the premium center and all that. But even with that premium, we want to see how we can streamline it and make sure that, because if we are doing free primary healthcare, then do we still have to have that premium, and what kind of percentage does it contribute to? But there's a whole discussion around it that I cannot talk about.
When all things being equal, would it take effect? When do you want it to take effect?
So I think, Winston, there's what the tariffs I'm talking about. You are talking about the premium. I'm talking about what the providers are paid for each of the services. That's why I was asking for which, and that one is going to increase quite significantly. Because they're saying that, okay, if I treat hypertension, I'm not being paid what I really should be paid. And we're saying, okay, we hear you. There's a process in our law, the Act 852, which makes it imperative for us to review this. And we've had a comprehensive review. It started sometime even before I came. And so we are winding down on it, and we're looking at the figures. And it would be a significant cost to the budget. So we need to make sure that we do it properly, and we need to make sure that even as we roll it out, we are closing the loopholes.
Okay, and because you talk about a significant cost to the budget, significant costs are always justified. If you don't mind, you can tell us what's the justification for this review?
No, so like I said, because it's like going to the market. Prices change. So in our law, we're supposed to actually do this every year. This was we have a minor review, and then there's a comprehensive review. This was a really comprehensive. So it took a little bit of time. We had to go back and forth with the stakeholders and so on. So that's why we've taken more than 2 years to implement this. But it will be really significant.
Dr. Victor Asare Bampoe is our guest this morning. He's the Chief Executive Officer of the National Health Insurance Authority. Doc, how much do you get from premium payments and renewals compared to how much you get from the levies? What percentage do you get from the levies that you get?
Over 90%.
90% of the levies?
Yes.
And renewals is
is about, it doesn't even get to 10%.
Yeah. So with the introduction of the free basic healthcare, with your target of increasing subscription to 70%, which will possibly take us to say 29 million people, your current funding sources and funding mechanism, will it be enough to carry the National Health Insurance Scheme through without putting a lot of debt on you?
I think it is doable.
Or should we increase the levy so you can 30.5% levy?
First of all, we must make do. You see, it's a journey. It was capped, it's been uncapped. There's quite a significant amount of funding. I said 3.5 billion extra. Let's see what we can do with it and make sure that we're efficient with the use. Remember, we're in an environment where we need roads, we need all this. So we need to justify why the funding should still come to us. So for me, I believe that the quantum is important, but the efficiency is more important. And for now, I think we're on that, on that pathway to make sure we get efficiency. Then we are looking at sustainability and are there other sources of funds and so on. Yes, we're looking at it.
Yeah, well, but if I get what Kojo is saying finally on that, because as you increase, it means more people.
Yes.
The expectation is that annually there would also be an increase in SNIT contribution and an increase in National Health Insurance Levy and increase in subscriptions. But if that doesn't happen, assuming we're holding the current amount constant, with the kind of increase in subscription or in members that you're seeing
and
tariff, would you have enough funds to run the scheme?
Yes, so you see that there are lots of balls in the air. Remember that the VAT regime has also changed.
Yes.
That VAT, that the input output is going to potentially bring us more resources. So there are so many variables that are in place that we are looking at.
Okay.
But for now, we think that we're good. We've run the numbers, for example, with free primary healthcare up until 2027, 2028, 2029, and it's looking good. Making certain assumptions about reducing fraud, making assumptions that once the Ghana Medical Trust Fund takes off, some of the cost that comes to us will be reduced. In the medium to long term, remember that the prevention and promotion of the health care would reduce some of the chronic diseases. So there are lots of things that are in play.
Now, someone just sent this message as we wrap it all up. Says, Dr. Victor Asare Bampoe is a unique leader who's won the hearts and minds of his staff at NHIA, and stakeholders are more comfortable working with the authority. There's somebody who works with you and, sent us this message. So thank you very, very much for joining us this morning. Anything you want to say finally, Dr. Victor Bampoe?
No, so just to say thank you to the person who sent the message. I need to actually congratulate the staff at NHI. Number one, I'm so privileged that His Excellency the President gave me this opportunity to serve. There are 30 plus million people, and it's an honor and a privilege to serve. I have a fantastic boss who is the Minister of Health, a fantastic board chairman and board. Most importantly, the staff at NHIA, sometimes they don't get the recognition they deserve. I've worked in many organizations around the world, and I keep telling the staff, they are some of the most dedicated, some of the most knowledgeable, and some of the most fantastic staff. And they are doing a good job, and I congratulate them heartily. And I say that I think Ghanaians should give us the opportunity to show how much of a difference we can make in this space. Thank you.
Yeah.
Great.
Kojo. I can't last question, but me busana on mommy answer. We are proposing that fufu and akukon coin be added to the approved drug list of National Health Insurance. So that when people go to the hospital, you bomb coin before we do the vitals. What do you think?
I was listening to this one. I'll take off my NHIA hat and I'll say that as a private citizen, a good plan.